the giant time. It's my pleasure and our honor to announce the starting of Middle East Venous Forum Conference. We have 6 giant speakers will contribute their experience, the vast experience in phlebology with us. We'll start by Professor Martin Marsh, Professor of Vascular Surgery and Head of Vascular Surgery Department in the Air Defense Hospital in Bahrain. Please play the video. Population
is getting older. This is the main algorithm of the management. After the diagnosis, we start the anticoagulation. Some of the patients are not ideal candidates for the anticoagulations, and it's contraindicated. These patients are getting IVC filter, but this is a very small group of the patients. It's important to distinguish between the distal and proximal obstructions, since the distal occlusions usually doesn't cause such a significant clinical impact. Anyhow, I want to comment that this group of patients supposed not to stay without the treatment, but it can be treated with anticoagulation alone. The length obviously depends on the cause of the thrombosis. This patient doesn't need to be admitted in a hospital. There is no benefit of doing it. We ask them to move around, put a compression stockings. That's the appropriate management. But here we are discussing the group of the patients with a proximal obstruction, because this group of patients we treat much more aggressively. And why we do that? Because the anticoagulation in these patients doesn't prevent venous hypertension in later course of the disease, and the morbidity of this venous hypertension caused by the proximal obstruction is very, very significant. So having these endovascular tools, we have these patients with reasonable risk, they should be a candidate for much more. And this is the mechanism, how it works. The proximal obstruction, it's basically working as any drainage system from the garden. If you have obstruction, the level is rising and the pressure is getting higher. In the literature, you can find the incidence of post-thrombotic syndrome of about 25 to 7. But I like much more this paper of Nikos, and from the clinics and from our experience, we can see that basically all the patients with proximal obstructions are suffering from some kind of venous hypertension, chronic venous insufficiency. Some of them just having a mild edema, but many of them are suffering from venous claudications, mutilating edemas, and venous. And I'm talking about them very young. So that's why the proximal iliofemoral thrombosis we deal with much more aggressively. The catheter-directed thrombolysis or pharmacomechanical thrombectomy, very often in combination. But we know from the statistics that around half of these patients, they need also venous stent. So this is one group of the patient. The other group of the patients are patients which missed this initial treatment. They get into the chronicity. It means more than 6 months of obstruction. And these patients, they unfortunately don't have any option of thrombolysis or thrombectomy anymore. The thrombus has completely changed the structure, but they can get benefit of stenting itself. So the goal is to provide the unobstructed drainage from the lower limbs all the way up to the atrium. It's a first line of treatment. It's recommended by all major bodies of vascular and interventionalists. And we can ask Glovitsky that it's in a pocket for very, very special cases. The problem is to find the ideal venous stent because it's supposed to be crash resistant, it's supposed to be flexible because of the course of the iliac veins. It needs a high radial force and also durability because these patients are usually young and this stent is supposed to be working for many, many years, which is very difficult actually to combine all these characteristics. Another issue is the shape of the stent because there is a lot of forces in the pelvis. The stents are compromised by the compressions, and you can see this is the consequence of the flow and relationship in between the shape of the stent and the flow. So there is a lot of different stents on the market. It depends where you are working and how much of financial risk you can get. The problem with the veins is that they are very large and they are very tortuous. So you have to find the stent which keeps the shape, and as you can see here from this image, you can see perhaps that the silver vena is keeping the shape. But unfortunately, silver vena is also the stent with the least radial force. This is a new concept because the companies, they understand the needs and they are trying to come up with the ideal stent. This is the stent which has like different segments of a different characteristics. The beginning where there is a compression of the iliac artery, it's a very strong, then it's a flexible segment, and then strong again because then there is a compression from the iliac. The issue is also the accuracy of the deployment, and the stents are having different foreshortening. I put the Boston Scientific as a very specific because it really is unpredictable. But on the other hand, we pay by predictability. We pay for the radial force because the wall stent is still having the high force. Another issue is the fracture below the ligament because unlike in the arterial bed, the venous stenting very often needs all the way to the ligament. So the conclusion, the venous stenting is in many cases unavoidable. It's not like in the arteries where you can just do prolonged ballooning. In the veins it doesn't work this way because the lesion is very elastic. You have to do proper stenting from healthy to healthy, from good flow to good inflow to good outflow. Otherwise it will get thrombosed. So it requires very long stenting very often. The sizing itself is very important, and I want to highlight the role of IVUS in these cases. And at the end of my presentation, I can tell you there is no ideal venous stent, so you can just choose whatever is available, and we are still waiting for the companies to come up with the solution. Much for this opportunity. I'm very happy to answer the question. I will make myself available online, and all the best to the conference. Thank you very much.
Thank you, Martin. It is a very nice presentation, and of course, you illustrate a lot about how to choose the best venous stent. Now I'm honored to introduce my dear friend, Professor Francesco Serino from Abu Dhabi. He is going to discuss a very interesting topic, and it is one step forward in the venous surgery. He is going to discuss opening and HIFO program in MENA, initial challenges and successes.
Thanks so much. So I'm honored to present this, and this is actually an initial, like say, pioneering attempt in Middle East. So first of all, I think I want to present the way I organize my work. I mean, the leg health, actually company, the leg health constellation, we call it, with the venous lymphatic and podiatry and vascular diagnosis. This is all in the area because you cannot work without these systems. This is the first things I always say. This is what is important in any treatment of varicose veins. Now, we are talking today about HIFU. HIFU, it's, I just say now, it's not the Armageddon of any other things. It's just another tool that we can use. What is important is we have keep in mind what we are designing to what we have to do, which is a precise investigation for just getting the best treatment available for that patient. So important is correct ultrasound to see, identifying precisely what the hemodynamic point of reflux, assessment of the deep venous system, and which technique is appropriate comes after, not before. This is because many times you see varicose veins, but not always it's saphenous vein problem. Sometimes you have an anomalous saphenous vein junction, sometimes it's an anterior accessory saphenous or posterior accessory saphenous. So most of the time I see people treated by saphenous vein, greater saphenous vein or small saphenous vein without any precise investigation, just for getting an operation done. So what is the, I've been, before presenting, they were presenting already, so you know most of it, but the new thermal ablation system, or guys, is the HIFU. What is the HIFU? It's a big machine, and actually it's pretty costly. So it aims to do extracorporeal treatment, so you don't have to do incisions. The waves are actually they're just targeting the vein from abroad. How does it work? So basically, what you have acoustic acoustic waves coming, and they are deployed as a conus, and they are addressed by ultrasound targeting to the vein treatment you want to do. So there is a robotic arm which actually helps you moving the systems along the design veins that you have been treating. So what you have a system with also a cooling top. So the bottom part is the cooling system, because of course to avoid injury, thermal injury in the skin. What is the key principle is that you have high intensity ultrasound. They are like a cone. So when they pass through the skin, they are a single. They are basically single waves which are not burning, but they converge at the end and they produce a thermal effect. This is exactly when the same thing when you use a lens to light the fire. So you put the lens at a certain distance from the focus, and then you are able to induce the fire with the sun exposure. Sun rays are coming parallel, but you converge them with the lens. This is exactly the same thing. Also, you need to have a system which is automatically in this machine of energy and pause. Pause because you need to have the tissue recovering from the thermal injury. And how does it work? So it's all the waves are converging to 2.4 centimeter from the depth. How do you do this? So you have the focus. So what you have to do, you need to press, and so that you compress the vein, because compressing the vein, then you can actually allow then the vein to be closed, because what you're eating as exactly as we do with the laser radiofrequency, you need to induce the thermal ablation of the wall, not of the blood. So you don't want to thrombose the blood, but you want to induce thermal ablation of the wall. So you need to aim to the posterior wall first, and then anterior wall. So it takes time. And actually it is a procedures which require some sort of attention and time. The effect is the same fibrotic effect of laser and radiofrequency. This is 30 days. So this is actually a little movie about how the things work. So this is comes from the company. So you have actually the patient on local anesthesia or no anesthesia lying on the table. Then you move the arm, which is robotic, so you can move it and you start actually firing on the vein, and then you keep going down. You can go down with the robotic arm, so that makes your life easier. So what is the challenging we find in the region? So we're talking about the Middle East venous form. So first of all, to get this machine authorized, it took almost 6 months. Negotiation, we are now negotiating with the insurance company because, of course, reimbursement is a big issue. The machine costs a lot. So in order for the investor to return his investment, you need to negotiate a good price. And this is actually what the phase we are facing now. So the cost also is high per session because you need to include also some disposable, which is the cooling system. And length of procedure, as I was saying before. The key point is that HIFU requires careful planning. It's not for all patients. Absolutely, it's not for all patients. So it can be one tool that you can use instead of the others if you believe in that. You need patient selection, very accurate, and high ultrasound skills. There's no way nobody or somebody without ultrasound skills can operate this machine. This is in response to what we said before about these general practitioner, family medicines, and other specialty going in treating varicose veins. This is the key point. It's very important. And you need to associate this with other procedures like phlebectomy or sclerotherapy. And in my opinion, is suited for hemodynamic treatment, what Sergio was presenting before. If you don't buy this concept, there's no way you can do an ablation of total greater saphenous vein like laser radiofrequency with HIFU. It takes 1 hour or more. It's impossible. So this is what Sergio was saying before in his presentation. So hemodynamic tailor is hitting the point of reflux and closing the point of deflux. So this is the three points. This is the initial experience we had. This is actually in our training part. We have results at 3 months. In all cases, I'll go back. In all cases, we have complete closures of the saphenous vein at 3 months, except for one patient, and this is when actually it's a good part of learning when you do mistakes. So in one patient, we realized after 1 month we actually didn't close the saphenous vein, but what we discovered that the saphenous vein became continent. So before we had a reflux from the saphenous femoral junction, we didn't find it anymore. So this is very interesting. By mistake, we end up regaining continence of the valve, of the terminal valve. Again, by mistake. So, in conclusion, the HIFU treatment, it's an exciting, innovative tool. Yes, very exciting, need to be investigated. You require high technical skills and proper training. No way anybody can do it. It's not a video game, it's not a PlayStation. Time to treatment is a problem. So, you need to, actually there is a problem in a learning curve, but it's also a technology problem. So there is time because of the technology. You need careful patient selection, and in my opinion, you can only do it or use it if you buy the concept of the hemodynamic tailor therapy. Not for all. It's not for everybody. And as Sergio was saying a few years ago, if we go and we give the machine to everybody, this is going to open the door to hell. So thank you so much, and I hope to be able to answer questions.
Thank you, Professor Francesco, for this nice presentation. Thank you. Next speaker, management of venous injuries, presented by Samir. The questions at the end or at the end? Sorry, Dr. Ahmed. Management of venous injuries, presented by consultant vascular surgeon Samir Qusayr. consultant, Faisal King
First
Hospital,
of all,
Saudi Arabia.
Unfortunately, I cannot be there. I'm going to speak about management of the venous injury. First, we start with the peripheral venous injury. Upper extremity venous injury, ligation is well tolerable. We know at all review 103 compact venous injury, 63% review with a ligation without significant difference in the post-operative thromboembolic complication comparing with the repair vein group. But here recommend to repair the venous in the upper extremity if you have a proximal vein, axillary or subclavian vein, or you have concomitant extensive soft tissue damage to prevent compartment syndrome. Lower extremity, again, the same ligation is better tolerable and more common than arterial ligations. But if the injury are repairable and the patient is stable, then reconstruction of the popliteal, superficial, common femoral, and iliac vein injury should be given serious consideration to reduce acute venous hypertension and long-term morbidity. This is a nice review of the National Trauma Data Bank. They compare ligation versus repair of isolated popliteal vein, and they found no significant difference in the lower extremity amputation, in hospital mortality, and in hospital amputation-free survival. What about truncal venous injury? We're going to talk about the chest venous injury and then abdominal venous injury. In the chest superior vena cava injury, it has a high mortality, but if you use an endovascular occlusion balloon to control the bleeding, this will improve the survival from 56.9% to the 88.2%, and this is statistically significant. After you control the bleeding, you do median sternotomy and to control the bleeding by digital pressure or using Satensky clamp. If you have uncontrollable bleeding from the superior vena cava, it's advisable to give a bolus of 3 milligram adenosine to induce a short asystolic so you can achieve a quick suture repair, or you can put on patient on the CPAP pump. You need to watch for embolism during repair, and then you can decide to go with an open or endovascular repair after you control the bleeding. Let's enumerate vein injury. It should be repaired if patient is stable through a median sternotomy. But if patient is not stable, it then can be ligated, but you need to put the left upper limb on stockinette and need to monitor for superficial volar compartment pressure. If the pressure went more than 35 millimeter mercury, then you need to go and proceed with a fasciotomy. Endovascular repair has been reported with an encouraging result recently. Subclavian vein injury can lead to devastating exsanguination due to the communication with the pleural cavity, and this is a common injury during central line placement. It should be promptly controlled either by by doing balloon occlusion balloon followed with a cover stent, or by open repair by high anterolateral thoracotomy at the third or fourth intercostal space with adequate backing of the pleural space and putting pressure on the supraclavicular fossa area. If repair is dangerously cumbersome, then it's better to ligate it, and then you have to monitor the arm for sign of venous hypertension. What about abdominal vein injury? IVC injury, it's the most common injury, about 25% of all injury, and 30 to 50% of all patients will die before reaching the hospital. Even the people who reach the hospital, the mortality is still high, about 20 to 57 will not survive to discharge. So you can see IVC injury has high mortality. You need to avoid a vigorous intravenous fluid resuscitation because you can release the tamponade effect, and patient may end with massive bleeding like when you have in the ruptured aortic aneurysms. Also, injury to the infrarenal IVC, has best survival due to the ease of the access and tolerance to the ligations. What about retrohepatic IVC injury? Exposure usually is difficult and survival is very low. Mortality can reach about 100% secondary to the difficulty gaining control in this region. When the injury is identified preoperatively, then endovascular technique will likely provide better salvage than open approach. Ligation of the suprarenal IVC is poorly tolerable, so you need to avoid that and repair it as much as you can. If you decide to repair the IVC, there's 5 points or concern you have to think about it. First, do I need to reconstruct the IVC or just ligate it? If you decide to reconstruct it, what type of reconstruction? What is the optimal prosthetic graft? And how to preserve the renal and hepatic venous outflow and how to get exposure. And I'm going to go through all steps one by one. First, do we need to reconstruct the IVC? It's a controversial. Some people, they ligate all the IVC with no reconstruction. Some people do selective, and some people do routine reconstruction of the IVC. The advantage of just ligation of the IVC, it reduces the operative time and prevent pulmonary embolism from low action DVT and avoid graft-related complications like graft infection and graft enteric erosion, and reduce the risk of potential high output cardiac failure and the need for lifelong anticoagulations. Usually patients develop post-operative edema, but usually it is a transit and generally well tolerable if collateral venous drainage was preserved. This is a nice retrospective review of national trauma database. They look at the impact of the IVC ligation on mortality in trauma patient, and they found that ligation associated with the increased fasciotomy, deep venous thrombosis, and acute kidney injury, but not associated with increased mortality, major amputation, or compartment syndrome. So what they conclude that IVC ligation is reasonable in a damage control scenario. Then the second question, if you decide to reconstruct, what type of reconstruction? You can do primary repair, patch repair, or graft interposition. But the patency is worse if you decide to go with a graft interpositions. And then what conduit you need to use? Some people use autogenous vein, like interjugular vein, cryopreserved allograft, bovine pericardium, you make it like a tube, or Dacron or BTFE prosthetic graft. What after prosthetic graft, also it's yet to be established, it's controversial, should be BTFE versus Dacron, should be one with a ring or without ring, should be used a large 20 millimeter or small diameter graft 12 to 14 millimeters. So this is a controversial issue, but Quinon, he preferred to use a smaller diameter 12 to 14 ringed BTFE to promote faster velocity through the graft segment. And if you decide to replace the IVC, it's always better to form or to create a femoral arteriovenous fistula to prevent thrombosis and increase velocity of the blood inside the prosthesis. What about exposure? Infrarenal IVC, it's easy to expose it by doing right column mobilization and Cocker maneuver to mobilize the duodenum, and this way you can expose the IVC infrarenals. Proximal distal control of the IVC, it's advisable, it's not always possible. If you have an active bleeding, go and put your hand on the bleeder, control the bleeding, and move up and down till you get control. What about suprarenal IVC? You need to completely mobilize the liver by dividing the suspensory ligament. Exposure to suprarenal IVC requires extension of the laparotomy, sometimes to medial sternotomy or right subcostal incision and dividing of the diaphragm. Pectoralis approach using compliant endovascular balloon for infra-outflow occlusion helps to control the bleeding until you repair the suprarenal IVC. If you have an IVC bleeding, how you control the bleeding? Either by putting your finger, or you can put a sponge above and below, or you can use sometimes a Stetinsky to control the bleeding. What if you have a retrohepatic massive bleeding? Then you have to do four things. First, you need to clamp the infradiaphragmatic aorta, followed with the portal vein, then suprahepatic IVC, and then infrahepatic IVC. If you don't clamp the aorta, this can patient end with a severe hypotension and then cardiac arrest due to reduced venous return. So it's very important to clamp the aorta below diaphragm first, even we are dealing with the venous injury. You can do hybrid clamping by putting a balloon in the aorta first, then you clamp the portal vein, then you put another balloon in the IVC below the liver and one above the liver. And this way you can control and you can repair the area. When you do clamping, you do the opposite. You inflate the balloon in the suprahepatic IVC, then infrahepatic IVC, then the portal vein, and last the balloon you deflated is the aorta. What about atriocaval shunt? It also helps you to control the bleeding, so you can do a repair. You can use a size 8 millimeter endotracheal tube, and we introduce it through the right atrial appendage by putting a burr string, and you insert it all the way through the tear in the IVC, and you put a burr string above it and below. Or you can use a chest tube 36, size 36, like that. And again, after you put a shunt, then you have no bleeding in the IVC suprahepatic. You can go and repair the tear. Or you can do endovascular repair by putting a cover stent. What about portal vein injury? It's very rare, less than 1%, but mortality is high, about 20%. Sometimes you need to divide the head of the pancreas to get exposure by doing a stabler. And suprahepatic portal vein exposure usually do it by medial rotation of the right colon and Cocker maneuver. Portal vein can be ligated, but bowel may become massively edematous, may result in abdominal compartment. The reason why you need to leave the abdomen open if you ligate the portal vein. And second thing, patient may develop a patchy bowel wall necrosis, so you need to bring the patient for second look after 48 to 72 hours. And patient will require a massive fluid replacement. And long-term evidence found that the patient who survive a portal vein ligation, they do not develop a portal hypertension, but mortality is high, can range between 50 to 72%. Renal vein injury, left renal vein can be ligated, is well tolerable because blood will drain through the left gonadal vein and left renal vein and lumbar vein. But if you ligate the right renal vein, there's no collaterals, then you need to follow with a nephrectomy. Endovascular technique can be used to treat selective cases of intimal tear, false aneurysm, or IV fistula in the renal venous system. So in conclusion, elective treatment of venous injury include ligation, repair, or reconstruction. Patient selection is the key to good result, depending on hemodynamic status of the patient, accompanying injury, or type of the venous injury is truncal or peripheral. Peripheral venous injury associated with a low mortality and should be repaired, especially for gatekeeper vein. However, primary ligation is well tolerable, whereas the truncal venous injury carries significant mortality and should be repaired always when feasible. Of course, endovascular technique carry great success with low mortality in the management of the venous system and injury. Thank you very much for your attention. Thank you.
Thank you, Dr. Sameh Qusair, for a nice presentation. I present Dr. Ma'moon Bashir. He represents a report of the first 100 cases of endovenous glue ablation. Is the concern justified?
Thank you so much. Well, first, let me thank my good friend Ayman and the organizing committee for the kind invite. It's a pleasure always to be in Egypt, and it's more of a pleasure to be in such a beautiful place, which I've had a chance to look around yesterday, and it's an amazing spot in the meeting point of the River Nile and the Mediterranean. And as always, Egypt is my second home, and I love being here. So I'm gonna present to you one of the modalities or methods of treating venous disease or superficial venous disease, endovenous methods, and this is the use of cyanoacrylate or endovenous glue. Treatment. I'm glad and happy to see that albocasis has been appreciated in this conference, and I happen to have a special interest in Islamic and Arab medical history, and I've done a thesis on albocasis, and we're all pleased to know that the way we do varicose vein surgery today is exactly like albocasis described it 1,000 years ago, down to the nitty-gritty of the steps, and it hasn't changed much. And this is, he's considered to be the father of modern surgery, and a lot of things he did were quite innovative. A treatment of venous disease, superficial venous disease, has gone through many stages. Over the last 20 years, we have seen the advent and the development of various endovenous methods, and we progressed from ligation stripping, sclerotherapy, endovenous laser, radiofrequency, etc. And glue is not the final step. We heard earlier about HIFO. However, there is no one step which is the answer to all forms of this therapy. It's a spectrum of treatments, a spectrum of disease, and a spectrum of treatments. And the basics of treating superficial venous disease are still the same. So if we go through the SEEP and the clinical classification part of the SEEP, there are stages that we treat. We use these endovenous methods for the sake of the juniors, they're only indicated when you have a degree of clinical complaint that warrants it, because veins are not easily disposed of, and if you only do that if they become symptomatic or they advance in stage beyond C3. Venous reflux, however, defines more of an indication to treat superficial venous disease, because it's a serious and progressive disease, and it's the key to most of the symptoms in my practice, and I do quite a bit of veins, if there is no reflux, I do not treat these veins, or I treat the cosmetic part. Venous reflux is an essential part of the pathology that you, when you treat, you can make the patient avoid a lot of the complications in the future. So I could not stress it enough that, look for venous reflux in adequate hands, and sonographers who sort of trained in this field can confirm to you the degree of reflux and how important it is. We can see from this graph the progress of using different methods of endovenous therapy. So, on the expense of surgical therapy, endovenous methods have progressed gradually, where, at this stage, we're getting most of the treatment either by endovenous ablation or injection sclerotherapy. So surgery is less and less used. Surgery still has a place, but this is the nature of the development of the therapy. And because of the excellent results that we can gain with endovenous therapy, we're further encouraged to use these methods. Which brings us to the subject at hand, which is using endovenous glue. So the main component of endovenous glue is cyanoacrylate, and it's a special formulation of cyanoacrylate that has a very heavy molecular weight. So cyanoacrylate adhesive closure has been around for about 15 years now, and there is enough evidence to recommend it to class 2 level A recommendation by the European Society of Vascular Surgery, where it's one of the, it is almost comparable to thermal methods. So it's one of the methods to treat endovenous therapy, or to use an endovenous therapy. And it has some attraction to it because, as advertised usually in these cases, is simple access under local anesthesia. There is no tumescent anesthesia to it. It's almost a day case or office procedure, and you need very little compression stocking afterwards. If you take it as in comparison to the other endovenous methods, it's quite comparable. So the rate of closure, or the complete closure, the success in complete closure is comparable, and the length of that closure or recanalization rate is also quite comparable. So that's why it's considered by many experts to be comparable to the thermal methods. In fact, in the review done by the European Multi-Center non-randomized cohort study, it sort of suggests about almost 90% of vein occlusion rate, and a great improvement in the clinical score even at 3 and 5 years. With the recanalization rate, it's very comparable to the other methods, including RFA, which is sort of 93 as compared to 91%. And it maintains this comparability or non-inferiority throughout that period. So the difference between the thermal methods and the non-thermal methods, or the cyanoacrylate closure, is almost the same. Most of these studies have been done on the original cyanoacrylate preparation, which is VenoSeal, done by Medtronic. At 60 months, the follow-up, the closure rate is almost the same. So recanalization at the initial stage might be a bit higher for cyanoacrylate, but they meet up at about 5 years. In our center in Amman, we do quite a bit of veins, and we were encouraged for a period of time to do cyanoacrylate, mainly because it's an office-based procedure, so we do not need a hospital. And we do have the full setup for intervention. Ours is an exclusive vascular center that we deal with a lot of, including venous disease, a lot of the things in vascular surgery, which are done on day case basis. So we've done about 100, well, we've done more than 100, but I'm gonna go through the series of this 100 cases between 2018 and 23 using cyanoacrylate, 64 females, 27 males, 9 bilateral, 93 of those 100 long saphenous, and 7 of them short saphenous. Now, the preparation we use is not VenoSeal. We've used the Turkish preparation. There are two ones, Vena Block is the earliest one that we used. And I like the Turkish preparation for 3 reasons, to be honest. One, it's easier to use and faster. Second, it's definitely cheaper for the patient. Third, it's the comparable results of the preparation is almost is the same. So the chemical material and the manufactured material is the same. The delivery machine is a bit different, but the what we use is the same. So very close is the earliest one we used, and this one has the distinction that it has a light at the end of the catheter, so you can tell where you are with extension. It's very easy to use with a gun where you deliver step by step, you deliver the glue. However, I use the fast retraction method where I do not use the gun, I use a syringe, I inject it quickly and go back with the pressure along the vein. So literally once you're in the vein in the correct position, it takes a minute to finish the whole procedure. So pretty fast under local anesthesia. I have my own vascular lab and I have my assistant who is a vascular technologist, and by the time she does the proximal compression, I inject, pull it back, we're done. The potential side effects or adverse events with cyanoacrylate are well established and described by the manufacturers, and they're quite a long list of things, because at the end of the day you're injecting a chemical material into a vessel, and the spectrum goes from allergic reaction to thrombosis, so quite extensive. The procedure itself is quite simple. You scan the vein pre-hand, we identify the puncture site. Under ultrasound, we puncture distally, we go retrograde to the junction with the catheter, delivery catheter. We scan the common femoral junction, compress it to occlusion so that none of the material goes into the deep system, and then inject about 2-3 centimeters away from the junction and pull back until we do complete occlusion. And post-procedure, we immediately scan it, we compress it, we scan it, and we make sure that there is complete occlusion of the vein. So to the patient, it's quite a procedure, simple procedure. The only 2 things they usually complain of are when you give the material itself, it gives a burning sensation for a second, and in some people who are sensitive to pain, it can be quite annoying. You warn them about it pre-hand, and it disappears quickly after you've done the procedure. And for the other thing you warn them about is the feeling of pain along the vein for the next few days, and it happens to varying degrees. Some people suffer with it more than others. So we had complete intraoperative vein closure in 99 veins. In 1 vein, we had partial closure. We went back a week later, scanned it, and it closed then. All cases done under local anesthesia. Vena block was used in 76 cases, very close used in 24 cases. There are minor differences between the 2 devices. The basic principle is the same, and we followed these patients in between 3 months to 5 years. Complications. So we had thrombophlebitis in 21 veins, minor vein perforation in 1, DVT and thrombosis extension in 3, minor PE in 1, recanalization in 4. There were no mortality or anaphylaxis. And I'll attract your attention to these complications. Some of them are almost expected, because when you do the chemical closure of these veins, initially you're initiating a thrombotic reaction. So thrombophlebitis is not something that you do not expect, and it's, as I said, it's a varying degree. You usually compress the vein, you empty the vein before you give the material, and you compress it pretty well. So in many of these patients, 80 of them, you will not get this reaction, but in a high percentage, you will get a reaction. And this is the reason why we're talking about this, why we're talking about closure, cyanoacrylate closure these days, because of recent literature suggesting that there is a higher rate of complications for this method than other methods. And it's mainly this meta-analysis done on a huge number of cases in Australia and the UK and the US, which shows that there has been a reported incidences of complications from cyanoacrylate, which are significant. So we're talking about 13 deaths over the last about 10 years prior to starting this, 13 deaths, 7 strokes, 200 and 11 thromboembolic agents, accidents, sorry. And this is a quite significant number, to be honest, because it's not supposed to be a fatal therapy treating superficial venous system, nothing without risk. But this is significant to look at because you can then look into should we be using it first, and second, should we modify it at all? And that's one of the reasons where the concerns are raised, especially with two imminent problems, which are the mortality and the strokes. Most of the mortality happens because of complications of TVT and thromboembolic disease and massive PEs, in addition to sepsis and anaphylaxis. Anaphylaxis is very unpredictable and it's difficult to predict it, but in any setting with these
1 minute, please.
So that will take us to the next slide, where you decide on these things. Patient and doctor depends on the consent process, and you explain it well to your patient, and they accept all pros and cons, then you go ahead with it. In conclusion, it's an effective procedure with comparable results of thermal methods. It's office-based. Our data correlates with the recently published literature. There is a rate of complications. There is a reason, from my point of view, to be concerned and selectively recommend the procedure and take the appropriate precautions, from inability to leave well alone, from too much zeal for what's new, and from treating patients as cases, from making the cure of a disease more grievous than its endurance. Good Lord, deliver us. Thank you.
Thank you. Next speaker, Professor Karen Bauer, talk about novel venoactive medications. Where is the science?
Hello, everybody, and thank you for being here. Thank you to the organizers for allowing me the opportunity to talk about this very important topic, especially when we're looking at chronic venous disease and venous leg ulceration. So kind of to start this off with the summary, that our guidelines for venous leg ulceration suggest against routine use of anti-inflammatory therapies for venous leg ulcers. The same is true of antibiotics. So we should not be using antibiotics routinely. What the guidelines do recommend are the venoactive medications. So research supports the use of pentoxifillin and MPFF, which we will talk about. But again, we have to look at the whole patient and make sure that we are doing all of the other things that we would usually do for chronic vein disease patients, as well as venous leg ulceration patients, like the endovenous therapy, elevation, compression, all of that good stuff. So the pathophysiology, obviously, of CVD is complex, but important to understand the biochemical nature of this, especially when we're looking at the venoactive medications. So if you kind of skim this, you can see, kind of in summary, what I want to emphasize is that glycocalyx and the inflammatory processes that circle around all of these endothelial changes and the structural and physiologic changes that are occurring in the vein in CVD. So when we look at it at that biochemical level, that's where a lot of these venoactive medications come in. So important to understand that complex pathophysiology. So again, kind of a summary there, study done recently here, 2024, that really looks at that in-depth cellular mechanism of what's going on in chronic vein disease. A couple of summaries here. So these are most of the medications that are venoactive that have been looked at in the research. You can see there whether there is an actual therapeutic recommendation for these agents or not. Not everything is also FDA approved for use in the States, but is used globally. The four that are actually guideline and or research supported are the MPFF, pentoxifillin, sulodexide, and then mesoglycane, which are the four that we'll focus on today. Another similar study, this was back in 2016, kind of a summary of the same, where we're looking at some of the medications that have been studied in the research. It used to be that we used horse chestnut quite a bit. That has kind of been replaced with some of the more modern venoactive medications. So one of the most common medications that we use is pentoxifillin. This was initially developed to treat PAD. It's a xanthine derivative. It has a powerful inhibitory effect on that cytokine-mediated neutrophil activation, that inflammatory response that we're seeing within the endothelial wall and within those veins as we progress throughout the stages of CVD. So it's an anti-inflammatory, also will help with the venous return. It does this by inhibition of the tumor necrosis factor A, the leukotriene synthesis, so again, these inflammatory cytokines. It's going to improve the red blood cell deformability, so the blood is actually going to flow through the vessel more efficiently. We're reducing blood viscosity and decreasing platelet aggregation. Again, pentoxifillin is research and guideline supported. Contraindication is recent MI, and then I always warn patients, the biggest side effect that we usually see with the pentoxifillin is GI. So I let them know about that. Try not to preempt that in them, but I do let them know that that is a potential side effect with that medication. The sulodexide, this is a medication that is not approved in the States, but is often used elsewhere. Similar mechanism of action with the antithrombotic and pro-fibrinolytic properties. So this is going to reduce the formation of blood clots. It's anti-inflammatory again. So as I talked about, understanding that biochemical inflammatory response that we have in the vein, that's where a lot of these medications are working. It is made from porcine digestive mucosa, so important to know that. And what it does is decrease some of that protease secretion so that we are anti-protease activity. Again, it's that anti-inflammatory effect, which can help improve the venous symptoms. Side effects of this medication, generally cutaneous rash, again, GI upset, some patients with headache. This is a medication that is usually given IM or IV initially for 15 to 20 days and then transition to the oral form. And you do that about twice yearly. So this is not a medication that you need to be on consistently and routinely, whereas the pentoxifillin is something that generally patients are going to be on for the remainder of their lifespan and or until the venous leg ulcer closes and we can ascertain that they're doing the things that are needed and don't have the recurrence. Mesoglycane, similar, so this is also extracted from porcine intestinal mucosa, again, composed of heparin sulfate and dermatan sulfate. This has a protective effect in venous thrombosis. Very few side effects here. This is a medication that is also sometimes used topically in venous leg ulcerations, can reduce the severity of chronic venous disease signs and symptoms, edema, that heavy fatigued feeling, and it can accelerate ulcer healing. So this is a medication that is generally at about 100 milligrams POQD. This is another one that is taken consistently throughout the duration. One of the modalities that I want to focus on the most today are the micronized purified flavonoid fractions, or MPFF. Again, this is SVS and AVLS guidelines supported, both for chronic venous disease as well as lymphedema. These are medications that I generally will have my patients be augmenting their care with, especially in the setting of venous leg ulcer. So this is a study that was done all the way back in 2005. We've been looking at these medications for quite some time. The MPFF is actually a food additive versus a prescription medication. So this is one that is essentially over the counter. There are some companies that will do prescription to help with insurance coverage where possible, but for the most part, this is considered a food additive. So again, it's something that patients can get on their own. You can see here the MPFF mechanism of action. Again, we're working on that cytokine, the inflammatory process that's going on. So essentially, we're going to decrease the cell adhesion molecules, so the leukocytes are not going to be able to adhere as well. We decrease the microvascular permeability and decrease the edema. At the same time, the MPFF will help increase venous tone, increase the efficiency of the capillary function, and increase lymphatic tone. So again, these medications, they're taken daily, generally twice a day. This is something also that the patient will need to be on for the duration. Oftentimes, anecdotally, we haven't seen patients improving with the MPFF for generally a month or two. So I tell patients to at least give it about that time or that amount of time before we decide to either continue it or not. I do want to emphasize with the MPFF, it is not just diosmin. So if you go online and you search this, there are different formulations. The key here is that the formulations that actually have research behind them will have more than just that diosmin. So they are a combination of flavonoids. Some smaller anecdotal studies on the effect of omega-3s in venous leg ulceration. So essentially, again, with that inflammatory process and whatnot, these were smaller studies. This is something that I will think about adjunctively in venous leg ulcer patients, not something that I am using as a first line like we will the pentoxifillin or the MPFF. Again, just to touch on this is something, the horse chestnut that was recommended in the guidelines previously. So sometimes if I have patients that either can't afford or don't have insurance coverage for the pentoxifillin, or they have the GI side effects, this is also a food additive. This is something that is a supplement, so it's something that the patient can get over the counter. Looking at similar symptom reduction with pain, pruritus, edema. There is no research that horse chestnut helps accelerate or speed wound healing in our patients with CVD, so this is not something that I am, again, using as a first-line adjunctive therapy. I kind of want to leave you with the idea, this was an editorial article by Dr. John Chuback and Mark Moline and colleagues recently that equates the CVD and the lower extremity edema situation, the parallel between congestive heart failure and congestive lower extremity failure. And I use this to emphasize that essentially all lymphedema is, or all edema is lymphedema. So when we're looking at the chronic vein disease and we're looking at venous leg ulcers, these venotonic medications are really important because we have all of the microcirculatory inflammation that's leading to our ulceration. So these are one way that we can help combat that. Looking at that as well and making sure that we're addressing the edema not only on a macrovascular level, but also a microvascular level. Couple other things. There are some localized compression garments that can be used, but of course, the way that I always look at CVD patients and venous leg ulcer patients is that we need to build a toolbox of useful tools around them. So at any given point, we may be throwing things in and taking things out, and that essentially there isn't one thing that is going to be fully effective. So we have to look at the endovenous therapy, add the venotonic medications, but we also have to make sure that we are giving the macrovasculature some support. And if the patient has a venous leg ulcer, it's a good idea to start to look at the local compression of the ulcer itself. So thank you very much for that quick summary on venotonic medications. Again, I think in summary, the biggest ones that are research supported that we really should be making sure that we're adding to our patients with CVD would be the pentoxifillin and the MPFF, and then the sulodexide and mesoglycane if you are outside of the States. Thank you so much. Happy to field any questions.
Later on we get that. Yeah, be with us, Bernard. Thank you, Dr. Karen. And now we invite Professor Munir Nazar, Professor of Vascular Surgery at Toledo University and the President of the Middle East Venous Forum. We speak about venous ulcer from diagnosis to treatment. Welcome.
For being part of this meeting. Unfortunately, I could not be there in person. My topic today is about venous ulcer from diagnosis to treatment, and a subject that's difficult to manage, as we all know. First, I have no disclosure related to this subject. Venous ulcer is a common problem, occurs in about 1.5 to 3 every 1,000 people. That increases with age to about 20 above the age of 80. The problem with venous ulcer is not very well known. What's the cause behind the venous ulceration? We all know what's the cause for post-traumatic syndrome and many of the venous diseases, but which patient will develop the venous ulcer is difficult to predict. Generally, 70 to 80% of venous ulcer patients have a primary venous insufficiency, and 20 to 30% have secondary to post-traumatic syndrome, and most of the time it is a combination of both. We cannot predict which patient will develop venous ulcer among those patients, and it is very uncommon to have a patient who present from the beginning with venous ulcer without going through management for venous disease in general. The other thing that we have difficulty identifying is not only the veins, there are other pathological problems, such as actually the muscle in patients with a stroke and patients who have obesity. It's a confounding factor in addition to that. Symptoms of venous disease in general are variable, and some of them present in combination. More than half of the patient will complain of aching pain. Others will complain of cramping, heaviness, swelling, and itching, but many of them will get those in complication. rarely they have severe pain unless the patient has venous ulcer. About 80% of patients who has venous ulcer develop pain, and sometimes it's severe pain, usually described as about 4/5/10. Once the patient presents with venous ulcer, we have to identify in history few factors, and in the diagnosis other factors. In history, we have to know the duration, the recurrence, and the presence of peripheral arterial disease. In addition, we have to identify other risk factors, and I'm underlying here obesity as being very important. In many of those patients, there is an element of arterial disease. In a study published in the British Journal of Surgery in 2007, about 13.6% of the patients with venous ulcer had moderate arterial disease, and 2.2% had severe arterial disease. Part of the evaluation, it should include evaluation for the presence of infection and potentially presence of malignancy, either by skin, by culturing the ulcer, and it should be a deep tissue culture, not superficial culture, skin biopsy from the edge and the ulcer looking for atypical feature and malignancy. In addition, it should include full evaluation of the venous system, which we will talk about later. Other things that we have to evaluate for and try to identify for management is obesity and depression, especially in people who are working. And the depression is not only in the patient, but in the people taking care of the patient at home. When we talk about venous mapping, it should be extensive venous mapping that include both occlusive disease and reflux disease. It should include the main named veins, which include in those cases the greater saphenous vein, the small saphenous vein, and the perforators. We should evaluate the presence of varicose veins and its anatomy compared to the ulcer and in the calf as well as in the thigh. We should also evaluate all the veins in the vicinity of the venous ulcer and in the area underlying the venous ulcer, like in this patient, which we'll talk about later. This patient, when we did the ultrasound, because he failed to heal his ulcer, there were a lot of veins in the vicinity and in the depth of the ulcer that had to be treated. Anatomical locations vary based on the ultrasound study and the accuracy of the study and the reporting. So you have a very wide range, like superficial veins are involved between 15 and 48%. Deep veins between 4 and 35% of the cases, or both of them 9 to 55% of the cases. This is a very wide range because of the problem with ulcer management and evaluation of the veins by ultrasound. In addition, in primary venous disease in 55 to 85% of the patient, and secondary venous in 14 to 45% of the patient. The role of MRV and CTV cannot be underscored here. It is essential to identify proximal occlusive disease, and both of them has the same value. It depends which one you can obtain earlier. In one of the studies we did in 2014, more than 36% of the patient had compression in the veins, and it's more in females than males. This is the treatment options in venous ulcer and diseases associated with venous ulcer. It is a wide range. We have to identify the pathology to decide which one of those we are going to use. This is our pathway for management at the University of Toledo. It includes identifying the deep system through CTV or identifying the superficial system with the ultrasound. A combination of management from endovenous surgery, compression, injection is being used for that. Typically, like any ulcer, we have to identify the presence of infection. We have to control edema, especially in patients with venous ulcer. Topical management is very important, including iodine and other topical agents. None of them is superior to the other. Compression is the most important part of the management. It has its problems, which we'll talk about briefly. In addition, biofilm management is very important, especially they usually contain staph and pseudomonas, and they are resistant to treatment by topical antibiotics. Wound bed preparation is very essential, which include infection control and debridement, and medical management or venoactive drugs, whether they have a role or not, can be used, and based on the guidelines, they have a role. Compression is very important. There are different types of compression. As you know, the problem with compression, not very well tolerated by many patients, especially when they have a high element of pain, and it is associated with other, it limits their social involvement, and many of them are not compliant with compression. A new device, which is, this is the newer version actually of this device, that's called the MolecuLite, which is a non-invasive way. It's an image that will identify the presence of bacteria in the wound. Its accuracy is about 65% compared to clinical accuracy of 29.4%. Its role so far is being evaluated in different studies, but it seems it has a role in identifying infection. Topical therapy to improve healing is also important, which including skin grafting, bioengineer the skin, and other cell substitute. In the United States, Apligraf is the only one that's approved for venous ulcer in general. What about surgery? Surgery has a wide range of options, from stripping, phlebectomy to ablation, whether thermal or non-thermal ablation. It depends on the availability in the centers, but a combination of those will be needed in most patients who have venous ulcer, but it is in a cascade form. They start with one thing, go to the second until you reach the last option. In our case, for superficial veins, we start with the ablations, phlebectomy if needed, and then very thin or injection sclerotherapy. And if there is occlusive disease proximally, we do endovenous therapy. But there is no clear winner among all those treatment modalities. Most of the time, you need more than one type. This is the patient we talked about. Patient failed to heal after doing everything possible that we know about until we identified the multiple veins in the depth of the ulcer. We injected using Veritina, and the patient started healing within 6 weeks, fully healed his ulceration. As for the deep veins, you know more than I do that there is no winning modality, but there are a number of them. The most important one is the endovenous therapy for iliac veins and the IVC. Everything else might have a role, but there's no proven evidence. There's no evidence in the literature is the choice for any of those cases. So in conclusion, venous ulcerations are multifactorial. Diagnosis of the underlying cause is essential, and treatment should involve management of all causes of venous hypertension and management of the ulcer in general. And thank you again for allowing me to be part of this meeting. Thank you very much for allowing me to participate in the conference.
I think now can we invite Dr. Francesco and Dr. Ma'moon Bashir, if anyone has any questions for both colleagues from the audience. Yes, Dr. Ahmed, yes, come on.
Thank you, sir, for your nice presentation. I want to ask a question about the new machine that treat the target varicose disease. If there is any recurrence rate after thermal ablation using this machine, if there is any recurrence rate after using this new machine, this is the first question. Second, what is the timing of recurrence, if it is okay? Okay, thank you.
The second question, sorry?
The timing of recurrence, if it is okay.
So there is no enough experience in the world, to talk about recurrence at this moment. For my experience, so we just started the use of the HIFU, and I have only 3 months follow-ups, and at this point, no yet recanalization. Recurrence, you need to distinguish recurrence, which is the clinical recurrence, so appearance of varicose veins, from the target venous place recurrence, which is the recanalization of the segment.
I mean by recurrence is revascularization. Recanalization.
There are no data, but anyway, as I said before, this is, in my opinion, that's an important topic. So it is impossible to think to treat the whole saphenous vein with the IFU. It takes too much. So if you want to do that, you need to adapt the saphenous sparing technique, which is you close only 5-6 centimeters of veins and leave the other things. I will tell you in a few years the rate of recurrence, but there are no data yet available. So it's a new, the machine is not new, it's from 2019, but there are few users in the world. United States is not approved yet, so there are data are not there. But anyway, you need to consider that as another thermal machine.
Okay, sir. Thank you very much.
You're welcome.
Yes, sir.
Congratulations, Francesco, to have. Congratulations, Professor Francesco, for having the HIVU technology. My question, in the technique of HIVU, you only ablate about 20 centimeters of the great saphenous vein. And usually we ablate the whole saphenous vein in our technique of laser ablation, let's say 45 centimeters. Do you think the results will be the same?
Well, that's the point. So I think we need to look at the IFU as a machine for hemodynamic saphenous vein sparing. So treating only 5-6 centimeters. That's what I did. I start doing, and I know exactly. So if you believe in the whole saphenous vein treatment, IFU is not the response, because it's impossible again. No, it is possible, but it takes 1.5 hours to treat 40, 45 centimeters of vein. So it's not the machine for that.
Please tell us about your opinion about the old operations like valve transplantation and venous bypass operations.
For superficial venous insufficiency?
For deep and superficial, for example, saphenopopliteal, femoro-femoral crossover, and interposition of vein valve segment. These old operations, what is your opinion about this?
In general, my opinion, I'm a surgeon in first place, so I love them. I still perform saphenectomy in case of saphenous vein.
Still perform valve transplantation and bypass operation?
Valve transplantation, not any longer. We don't do that, but just we do valve repair, yes. Like keister repair, yes. We do sometimes, and I believe, again, I still believe in the concept of repair. So I think if we find a way to repair or use endovascular in the deep vein systems, stent valves, I think I did use stent valves that was 20 years ago. The first to repair venous insufficiency with percutaneous stent valves for the venous insufficiency.
No, till now you did the old operations.
Yes.
Femoral crossover.
No.
And
femoral crossover, no, because in the vein it's not. I don't do that.
Of a vein valve segment.
Yes, we do. When it's needed, yes.
Valvoplasty.
Yes. Valvoplasty, yes.
Thank you.
Thank you.
Yes, you can. Give me the mic, please.
Dr. Mamoun, thank you very much for your nice presentation. We enjoyed and congratulate you for the success of the cyanoacrylate ablation of great saphenous vein. Actually, I'm asking about a technical point. Did you face any cases in which the cyanoacrylate stuck to the catheter and to the inside of the great saphenous vein, and you are trying to pull back the catheter and the cyanoacrylate already stuck to the vein, and how to avoid such situation?
Right.
Thank you.
Well, thank you for the question, and it's quite a truthful point. Technically, a lot of people, including myself, faced it when we started with VenoSeal, because the mechanism of delivery of the cyanoacrylate in VenoSeal is a bit different than the one I use. It's done 1 millimeter by 1 millimeter gradually, and it's a double catheter technique where you would, there are two catheters, and you deploy the cyanoacrylate from one catheter to the other to the vein. And it did happen, and when it happens, it's pretty annoying because pulling back your catheter, and usually it's done by force, can be very painful to your patient and very annoying. With this technique, which is the pull back fast technique, I've never faced it. It doesn't happen, mainly because you're delivering, and I deliver it by syringe. I don't use the gun. You deliver it pretty fast, and you're ahead of the delivery. So the catheter is back before you're injecting. The one thing I would caution people about when they use especially varicoclose is that it has a tip which is advanced more than the catheter itself. So you should be aware of the tip, and sometimes it's not very obvious on the ultrasound, and usually I like having a safe distance. So when I'm decided this is the location to inject, I pull back another centimeter or two just to be on the safe side.
So the end of this session. Thank you very much. Please, chairperson and speakers of session number 4, please.
The safety and efficacy of Zymos gel in the treatment of chronic venous ulcers.
The primary endpoint of the study determined that complete wound healing within only 3 months of treatment, Zymos gel is a safe and an effective topical treatment for venous ulcers. Indications: pressure sores, burns, post-operative wounds, and a variety of different ulcers. Zymos gel, do more with one. Zymos gel, do more with one.
We'll start session 4 and by Professor Maisa Abdel Wahab. She will talk about endovenous treatment of post-operative pulmonary embolism.
Okay. Thank you for Professor Mutwalli Rajab and Professor Ayman Fakhri for inviting you in my second home. Thank you all chairpersons and attendee, and all thanks to BCO company. I will talk about endovenous treatment of pulmonary embolism, team management. Acute pulmonary embolism is the third most common cause